And now, Lecture 4 and Part 2 of our series, where we shift from how drugs behave in the body to how they are controlled by law. In the first 3 lectures, we built vocabulary, learned drug classes, and followed a drug through the body. Now we're going to look at the rules that govern which drugs a patient can get, how, and under what safeguards. This matters enormously in your daily work because medical assistants handle prescriptions, help manage medication samples and supplies, and often work in offices that stock controlled substances. Knowing the legal landscape protects your patients, your office, and your own career. Here's our plan. First, we identify who regulates medications in the United States, mainly the Food and Drug Administration and the Drug Enforcement Administration, along with state boards. Then we sort medications into their legal categories: prescription drugs, over-the-counter products, and dietary supplements, and we'll see that supplements are regulated very differently from what many patients assume. Next, we focus on controlled substances, the drugs with potential for abuse, and we'll walk through the 5 DEA schedules and the special rules that surround them, including prescriptions, secure storage, record keeping, and programs that prevent diversion. Finally, we cover medication safety practices and your own legal and ethical responsibilities. Throughout, keep one theme in mind. These rules exist to keep powerful medications helping patients rather than harming them, and you are an important part of that safety system. Here are the learning outcomes for this lecture. First, identify the agencies that regulate medications in the United States so you understand who sets the rules you will follow. Second, differentiate the 3 main categories a product can fall into: prescription drugs, over-the-counter products, and dietary supplements, because the differences affect safety, patient education, and what you document. Third, describe what makes a drug a controlled substance and learn the 5 DEA schedules, which rank drugs by their potential for abuse. Fourth, explain the special rules that surround controlled substances, including how they are prescribed, how they must be stored and secured, and how they are tracked to prevent misuse. Fifth, apply medication safety principles and understand your own legal and ethical responsibilities as a medical assistant. Notice how these outcomes build from the big picture of who regulates down to the specific handling of the most tightly controlled drugs, and finally to your personal role as a medical assistant. As we move through this lecture, keep connecting each rule to a concrete task, such as taking an accurate medication history, handling a prescription correctly, or helping keep a medication supply secure. That connection is what turns regulations into safe, confident practice, and is exactly what employers and licensing bodies expect of a professional medical assistant. Before we sort medications into categories, it helps to know who makes and enforces the rules, because you'll hear these agencies named often. 3 levels of oversight matter most. First is the Food and Drug Administration, or the FDA. The FDA is responsible for reviewing and approving drugs as both safe and effective before they can be sold, and it oversees the drug labeling and manufacturing quality. When a medication is FDA approved, it means the agency has evaluated evidence that it works and that its benefits outweigh its risks. Second is the Drug Enforcement Administration, the DEA. The DEA has a different job. It enforces the Controlled Substances Act and focuses specifically on drugs that have a potential for abuse or dependence. The DEA is the agency that assigns drugs to schedules, registers providers who prescribe them, and investigates misuse and diversion. Think of the FDA as asking, does this drug work and is it safe? And the DEA as asking, could this drug be abused and how do we control it? Third are the state boards, including state boards of pharmacy and state medical boards. These set and enforce rules within each individual state, and this is important because medication laws, including exactly what a medical assistant is allowed to do, vary from state to state. So a task that is permitted in one state may not be in another. As a professional, you are responsible for knowing the rules of the state where you practice, and when in doubt, you check with your supervising provider or office policy. Now let's sort medications into categories, starting with the two most familiar, prescription and over the counter. On the left are prescription drugs, often abbreviated capital R, small x. These require an order from a licensed provider, such as a physician, nurse practitioner, or physician assistant. They are chosen and dosed for a specific patient based on that person's condition, and they are dispensed by a pharmacist. Prescription status usually means the drug is powerful enough or carries enough risk that the professional judgment is needed to use it safely. On the right are over-the-counter products, or capital O, capital T, capital C. These can be bought without a prescription and are selected by the patient for self-care of common problems such as headache, heartburn, or a cold. Instead of a prescription label, they carry a standardized drugs facts panel that tells the consumer the active ingredient, uses, warnings, and directions. Here's a key point that ties the two together. Both prescription and OTC drugs are FDA approved, meaning the agency has reviewed evidence that they are safe and effective when used as directed. The difference is not whether they were evaluated, but how much oversight is needed to use them. For your role, remember that patients often forget to mention their over-the-counter products because they don't think of them as real medicines. Asking specifically about OTC drugs during a medication history is essential because they can still cause side effects and interactions. This distinction sets up our next category, which many patients misunderstand entirely. This slide corrects one of the most common and dangerous misunderstandings your patient will have. Dietary supplements are vitamins, minerals, herbs, amino acids, and similar products taken to supplement the diet. Many patients assume that because a supplement is sold on a pharmacy shelf, it has been tested and approved by the government just like a medication. That assumption is wrong. Under a law called the Dietary Supplement Health and Education Act, passed in 1994 and usually shortened to DSHEA, supplements are regulated as a category of food, not as drugs. Look at the consequences on the right. First and most importantly, the FDA does not approve supplements for safety or effectiveness before they are sold. In many cases, a company can bring a supplement to market without proving it works or is safe, and sometimes without even notifying the FDA first. Second, supplements carry a supplement facts panel rather than the drug facts panel you see on OTC medicines. Third, and critical for patient safety, supplements can still interact with prescriptions and over-the-counter drugs, changing how those medications work. A common example is an herbal product interfering with a blood thinner. Fourth, the responsibility for safety and truthful labeling falls on the manufacturer, not on a pre-market review. For your role as an MA, the lesson is pretty clear. When you take a medication history, always ask specifically about vitamins, herbs, and supplements because patients frequently leave them out. Documenting them helps the provider catch interactions that could otherwise be missed. A controlled substance is a drug that has a recognized potential for abuse or dependence, and because of that potential, it is controlled by federal law. These are the medications society has decided need extra safeguards, such as many opioid pain relievers, certain stimulants, and some sedatives and anxiety medications. The legal foundation is the Controlled Substances Act of 1970, a federal law that created the whole framework we use today, and the Drug Enforcement Administration as the key that enforces it. Look at the key ideas on the right, which preview the rest of this lecture. First, controlled substances are sorted into 5 schedules based on their potential for abuse, and we'll walk through those next. Second, providers who wish to prescribe them must register with the DEA receive a unique DEA number, which appears on controlled substances prescriptions. Third, the general principle is pretty simple. The higher the potential for abuse, the tighter the control, which affects everything from refills to storage. Fourth, remember that state law layers additional rules on top of the federal system, and those state rules can be stricter. For your role as a medical assistant, the takeaway is that controlled substances demand extra care at every step, from how a prescription is handled to how the drug is stored in your office. Treating them casually is both a safety risk and a legal one, so the professionalism you bring to these medications really matters. This table is the core reference of the whole lecture, so let's walk through it carefully from top to bottom. The DEA sorts controlled substances into 5 schedules, and the guiding rule is that a lower schedule number means a higher potential for abuse. Schedule 1 is at the top. These drugs have the highest potential for abuse and, under federal law, no currently acceptable medical use, which means they cannot be prescribed. Examples include heroin, LSD, and ecstasy. Schedule 2 drugs also have a high potential for abuse, but unlike Schedule 1, they do have accepted medical use, so they can be prescribed under very strict limits. This is where many strong opioid pain medications live, such as oxycodone, morphine, and fentanyl, along with stimulants like methylphenidate used for attention disorders. Schedule 3 drugs have a moderate to low risk of physical dependence, and examples include products containing low doses of codeine, ketamine, and anabolic steroids. Schedule 4 drugs have a low potential for abuse and include many common anxiety and sleep medications such as alprazolam, diazepam, lorazepam, and zolpidem. Schedule 5 drugs have the lowest potential for abuse and consist mainly of preparations with limited amount of narcotics, such as certain cough syrups containing small amounts of codeine. You do not need to memorize every drug, but you should understand the pattern that the schedule number signals how tightly a drug is controlled. All of these examples come from the DEA Diversion Control Division, which is the authoritative source. As you gain experience, you'll start to recognize which of your office's medications are scheduled and treat them with the appropriate care. Because controlled substances carry a higher risk, the prescriptions for them follow stricter rules than ordinary prescriptions, and you may handle these prescriptions in your office. 4 points matter here. First, a valid DEA number. Any provider who prescribes a controlled substance must be registered with the DEA and have a DEA number, which will appear on the prescription. This number is part of what makes the prescription legitimate. Second, tighter refill rules. The higher the schedule, the more restricted the refills. Schedule 2 drugs, the strongest that can be prescribed, generally cannot be refilled at all, which means the patient needs a brand new prescription each time rather than simply calling for a refill. Lower schedules allow limited refills within set time frames. This is why a patient on a Schedule 2 medication may need to come in more often, and understanding that helps you explain the process to them. Third is electronic prescribing. Many controlled substances are now transmitted electronically directly from the provider to the pharmacy, which reduces the risk of forgery, tampering, and lost paper prescriptions. Fourth, and where your attentiveness really counts, watch for red flags. Signs of a problem include prescriptions with altered quantities, requests to refill far too early, and prescriptions that appear forged or changed. If something looks wrong, you do not accuse anyone, but you do bring it to the provider's attention and follow your office protocol. Protecting the integrity of these prescriptions protects patients and your practice. If your office stocks controlled substances, whether to administer in the office or to provide as samples, they must be handled with strict security, and you may take part in that process. Three responsibilities stand out. First, secure storage. Controlled substances must be kept in a locked cabinet or safe with access limited to authorized staff only. They are never left out where a patient, visitor, or unauthorized person could reach them. This single habit prevents a large share of medication theft. Second, accurate counts. Offices track controlled substance inventory carefully, often counting and reconciling the number of doses on hand against records of what was received and used. When you participate in a count, accuracy and honesty are essential, and any discrepancy, loss, or suspected theft must be reported right away following office and legal procedures. Third, record keeping. Federal and state rules require that records and inventories of controlled substances be kept for a set period of time, commonly at least 2 years under federal rules, though states may require longer. These records must be accurate and available for inspection. For your MA role, the common thread is diligence. Locking the cabinet, counting carefully, documenting honestly, and reporting problems promptly are not just office chores. They are legal obligations designed to keep dangerous drugs from being diverted, and doing them well marks you as a trustworthy professional. When you're unsure of a procedure, ask. Getting it right protects everyone. A major tool for preventing the misuse of controlled substances is the Prescription Drug Monitoring Program, usually abbreviated in capital letters PDMP. A PDMP is a state-run electronic database that records controlled substances prescriptions that are filled within that state. Each time a patient fills a prescription for a scheduled drug, that fill is entered into the database. Before we go any further, let's talk about the word that you're going to hear pretty often here. Diversion means moving a drug out of its legal intended use. For example, when a medication meant for one patient is sold, stolen, or used by someone else. PDMPs exist largely to detect and prevent diversion. Look at how they help on the right. First, they let a provider know a patient's controlled substance history across different pharmacies and prescribers, giving a fuller picture than any single office would have. Second, this helps spot problems such as the same drug being prescribed by several providers at once or combinations that are dangerous together. Third, by making that information visible, PDMPs support safer prescribing and reduce the chance that controlled substances are misused or diverted. Fourth, remember that these are state programs, so exactly who must check that database, when, and how is defined by each state's own law. Some states require providers to check the PDMP before prescribing certain drugs. For you as an MA, you may help gather information or support the provider's workflow around these checks, always within your scope of practice and your office's procedures, and always protecting the confidentiality of what you see. Beyond the legal rules, everyday medication safety prevents harm, and this is an area where you contribute directly every time a medication is prepared or given. The foundation is a simple checklist known as the rights of medication safety, and you should verify each one every time. The right patient, confirmed with 2 identifiers, usually the patient's name and date of birth, so the medication goes to the correct person. The right drug, making sure the medication matches the order, and confirming the generic name as we discussed in Lecture 1. The right dose, checking that the amount matches what was ordered. The right route, giving it the correct way, whether by mouth, injection, or another route. The right time, giving it when it's due. And the right documentation, recording what was given accurately and promptly, because if it wasn't documented, it's treated as if it wasn't done. Different sources list a few additional rights, but these core 6 will keep you focused on safety. Now take a look at the dark box because it names one of the most common causes of medication errors. Many drug names look alike or sound alike, such as pairs of medications with similar spellings or pronunciations, and mixing them up can seriously harm a patient. The safeguard is the same habit we have stressed all throughout this series. When something is unclear or doesn't look right, stop and verify before you act. Slowing down for 2 seconds to confirm is always better than a rushed error. These simple, disciplined checks are the practical heart of safe medication practice. We'll close out this lecture by focusing on you as an MA because everything in this lecture connects to your legal and ethical responsibilities as a medical assistant. 4 duties tie it all together. First, work within your scope of practice. Your permitted tasks are defined by your state law and your office policy, and they never include prescribing or diagnosing. Knowing exactly what you may and may not do and staying inside those limits protects your patients and your career. Second, document accurately. Whether you are recording a medication history, noting an administered dose, or taking part in a controlled substance count, your records must be truthful and complete. The medical record is a legal document, and falsifying or sloppily keeping it has serious consequences. Third, always protect confidentiality. Medication and health information is private and protected under HIPAA and your office rules. This is especially sensitive with controlled substances and with conditions that carry stigma, so you guard that information carefully and never share it improperly. Fourth, speak up and verify. If you see an error, a suspicious prescription, or a discrepancy in a controlled substance count, you report it honestly through proper channels, and whenever you are unsure about anything, you verify before acting rather than guessing. Notice that none of these require advanced authority. They require diligence, honesty, and good judgment, which are exactly the qualities that make a medical assistant trustworthy. And now the lecture's key points. Medications in the United States are overseen by several agencies. The FDA approves drugs as safe and effective, while the DEA controls drugs that have a potential for abuse, and state boards add their own rules. We sorted products into categories and learned an important distinction. Prescription and OTC drugs are both FDA approved, but dietary supplements are regulated as food under the DSHEA law of 1994 and are not approved for safety or effectiveness before sale, which is why asking about supplements in a medication history matters. We focused on controlled substances, drugs with abuse potential controlled under the Controlled Substances Act, and we learned the 5 DEA schedules, where a lower number means a higher potential for abuse. We covered the extra safeguards these drugs require, including valid DEA numbers, tighter refill rules, secure lock storage, accurate counts, careful record keeping, and prescription drug monitoring programs that help prevent diversion. And we grounded it all in medication safety, the rights of medication administration, and your own responsibilities to work within your scope of practice, document honestly, protect confidentiality, and verify when unsure. More information about this topic can be found in these citations that I used to put this lecture together.